Hey there, everybody. It's your girl Thalia. I'm back. I made some slides on my blood banking notes. So, in this slides, I'm going to discuss donors, processing, storage, components, quality control, not too much, just a little. And then I also made a vocab list that includes all key terms, all my high yield terms, the RH factor, screening, serology, storage, transportation, transfusion. I'm also going to talk about adverse reactions, serologic testing, and also going to cover infectious disease screening. So, because that's the point, we're going to start with collecting patient's blood and what happens after we get that patient's blood. And then we'll go from there. And I'll make another slide, another presentation on antibodies. And that will be a whole its own discussion. But for now, we're just going to focus on the beginning of blood banking. Donors. I mean, without them, we really don't have blood banking. So, shout out to the donors out there. For sure, y'all are the real MVPs of all of this. And so, with that, we want to make sure that our donors are good. Because if our donors are good, then the recipients are good, our patients, the ones who are sick and might need that very valuable blood. So, we got to make sure that the patient's good. So, at least they got to be 16 with some parental consent. Make sure that if they've donated blood in the past, that they're waiting the appropriate interval time. So if they've donated whole blood, they need to wait 8 weeks. If they donated a 2-unit collection, they need to wait 16 weeks. And they need to be free of any diseases, of any major organs and or cancer. They would get their vitals taken, and then they would make sure that their temperature is good, no fever, showing any type of signs of illness. Their blood pressure would also be taken. We would want that to be within the systolic diastolic ranges. Their beats per minute, we would want that also to be normal, and we would want them to be at least 110 pounds minimal to be able to take that amount of blood. And we would also want that the hemoglobin and hematocrit are also where it's supposed to be. Women being 12.5 grams per deciliter for hemoglobin, 38% for hematocrit, and men just slightly higher, 13.0 grams per deciliter for hemoglobin and 39% for hematocrit. And then, of course, we want to also ask the donor any types of questions that tests and vitals might not be able to tell us otherwise that the patient is healthy. So we got to ask the patient if they're on any types of medications, if they've traveled outside of the country that may predispose them to malaria, for example, or if they were ever around anyone that was ever around in the United Kingdom in the 1900s, because it's relevant to Creutzfeldt-Jakob disease. It's a prion brain disease. It's fatal. If they were pregnant, then they would have to wait after at least 6 weeks of post-pregnancy to be able to donate. We would also want to know if they've had any types of transfusion or tissue transplants. And depending on what it is, some deferrals might be temporary and some might be permanent. For example, if someone were to get a tattoo, they could wait about 3 months, 3 to 12 months, depending, I would say. And it's state dependent more so. And then again, if where they have traveled, and permanent deferrals would be like they can't ever donate ever, unfortunately, is if they're positive for HIV, hepatitis B and C, and like I just mentioned, the Creutzfeldt-Jakob disease, the prion disease with the rapid dementia. It really has no cure, and it does have a potential blood transmission. And so, yeah, we got to just make sure that our donors are good. Collection methods. In this next step, we begin preventing contamination. Now that we've confirmed who our patient is and that they're healthy and good to go, we start with the next critical step, and that's preventing contamination, making sure that whichever way that we collect our blood or our unit is collected safely, not just for the donor, but also for the recipient. So the phlebotomist is usually ones that draw blood. They're usually the ones on the big red bus. They also work in the donor facility places. They also work in hospitals, and so they collect blood all day, and they can either do it manually, a manual collection method where it's whole blood of red blood cells, and they also can collect FFP for plasma, and we usually freeze that within 24 hours after phlebotomy, platelets, cryo. And so they collect all of that through whole blood. All of these ingredients, they're in the whole blood. But what we do is that we separate them in the lab, right? And so it's pretty cool the way that we can do that. And then we also have the automated apheresis, where it's an automated machine that collects these components that we want. So it's selective. So if we want platelets, plasma, or granulocytes, we can just collect those and return everything else. The whole blood or red blood cell, we spin them down and we collect what we want. The cryo is usually what's right at the top. To me, that is, I think that is the golden liquid, because it has so many of the important factors, which we'll get into later, but that's really cool component. And then of course, with the collection methods, we also have to prevent the contamination. So when the phlebotomist goes to draw blood from the now correctly ID'd patient, two patient identifiers, date of birth and ID, name, what have you, they prep the venipuncture site using povidone iodine or isopropyl alcohol. And there's also a diversion pouch that is used when platelets or apheresis platelets are being prepared. And what the purpose of the diversion pouch is to detect bacteria, to reduce pathogens from being able to cross over and to cause some serious adverse reactions to the recipient. Adverse reactions related to blood donation. So it's important for us to know as MLS that there are possibilities to the donors being affected when they're donating, that there could have some type of reaction to it, some being more common and some being less common than others. For example, a hematoma is the most common form of adverse reactions from blood donation. And what it is that the arm bruises like a purple explosion, it gets very swollen and the arm can become sore for the patient. And this usually happens because of improper technique, because the puncture after the post draw, there wasn't enough pressure applied to the draw. So that's why it's important that after you puncture your vein, because what happens is that the blood, it leaks into the subcutaneous tissue and it causes that swelling and that bruising. And so whenever you puncture a vein, just make sure that after you're holding, an adequate amount of pressure to try to avoid a hematoma. And sometimes, they're unavoidable, because I've worked in hospitals and I've seen, or at a hospital, excuse me, and I've seen one of the best phlebotomists there, and we were just drawing an elderly patient, and she just got a hematoma, and we didn't do anything that would have caused that for her. It's just her skin was just very frail, and she was just very prone to the swelling and the bruising, because she was also on anticoagulants. That doesn't help. So it was just a couple factors that contributed to that. So sometimes it's not just improper technique, but just always remembering to always apply adequate amount of pressure after your draw is definitely important to know. And so the next thing that we we could see from a reaction is the apheresis related citrate toxicity. This happens, usually the patient feels like their lips tingle, like a sparkler maybe, but so they feel tingling in their lips and their hands. They can get cramps, and in rare cases, they can experience tetany where they clench their fist. And so it's important for us to know that the reason why this happens is because the citrate, the anticoagulant, it chelates calcium, so like it steals calcium, ionized calcium, excuse me, and so it zaps the nerves, and so this citrate toxicity. What we need to know how to be able to fix this issue is to pause the machine and give the patient like a calcium like Tums 500 milligrams, or in severe cases IV calcium for tetany. And so that does happen. And the next thing would be the allergic reactions. Allergic reactions do happen, and it's usually related because of the prep site from the iodine or the alcohol, the isopropyl alcohol itself. And it just, could be because the patient is sensitive to that. And also, it's also common, allergic reactions are also common in apheresis collection, because the apheresis could cause the immune system to react, and so it releases histamines, and so sometimes the patient can get itching and hives, and sometimes in severe cases anaphylaxis where their throat swells. And that would obviously, again, be a more severe reaction, but it's important for us to know if that were to happen, we'd have to immediately stop and administer epinephrine if we have to. And just, again, and it's important for us to just be able to know what to do by monitoring the patient during the period of donation. And so the next reaction is the vasovagal syncope. This is when the donor faints, and it's usually very common in first-time donors because of stress and anxiety. And they'll just faint within 5 minutes. They'll start to get sweaty, and they'll get dizzy, and they'll black out. And so what we would have to do as MLS, we have to know to stop the draw, tilt the chair back, elevate their legs. This is called the Trendelenburg position. And if we have to, we could, wave some ammonia out in front of them, try to wake them up. And, aside from them being nervous and anxious, this can also happen if over the volume is collected. So we try to stay between 450 to 500 mLs, which is equivalent to that 1 pint. But if it surpasses that, it can cause that fainting to happen. And also, that's why we also try to keep the patient within the minimum weight range, because if the patient is not at that range, they could also potentially faint, because it's just too much for them. So that's it. So the MLS takeaway from this, I would say, is just in processing ensures blood is safe and compatible for transfusion. So, guys, it's time to strap in, because from here it's going to get a little bit more complicated. So, as MLS students, you're going to be, at some point, you're going to be working in the laboratory. You're going to be in blood bank. You're going to get your hands-on experience. And so, if you have any instructors like mine, I had one that was like a drill sergeant. Really liked her. She was intimidating, but I like her. And she used to just drill my ass all day, for lack of better terms, and it just stuck to me. And so when you're in the lab, you're going to be running tests for blood type, antibodies, and infections, and separate components. And we'll detail serologic tests using specific antisera like anti-A or AHD, anti-human globulin, infectious screening, P24, CLIA, EIA, if you have heard of EIA and CLIA, and centrifugation, including intermediate spin. So we're just going to go ahead and dive right in. All right, time to get down to the nitty gritty. So buckle up because it's a lot of information. And I'm going to try to throw it as fast as I can to not overwhelm you guys. So bear with me. So for this phase, now that we finally have reached the processing phase of blood bank, okay, the types of tests that we're going to run into is to determine compatibility and safety for the patient is our goal here. So some of those tests, they include, so a DAT, not sure if you're familiar for a DAT, but I'm going to start with a DAT first because it's more a little bit of an explanation. A DAT is a direct antiglobulin test, okay? Now, this is not the first thing that we do. No, we're going to start actually by doing the ABO typing and the RHD first, but I want to mention the DAT first. And so we're going to do the DAT. This is a test that we test for antibodies or complement proteins that are already bound to the to donor or the patient for the red blood cells in vivo. That means in their blood. So this is in their blood, often to detect an autoimmune or hemolytic anemia or for transfusion reaction. And it's done on the donor red blood cells if there's a history of transfusion or suspected sensitization. What is sensitization? Okay. Well, that is, for example, with the RHD, the D antigen. So if for example, a woman is pregnant, she is RH negative, so she's A negative. Let's she's A negative, but her baby is B positive. Whatever. If the baby's A positive, B positive, doesn't matter. If the baby's RHD positive, then what happens is that first time moms, they when they give birth and the baby, there's a cross of their blood, right? So their blood has a moment where they cross, and so the baby's blood goes into mom's system, and so mom's system recognizes this positive D, because during pregnancy, she's given a medication to help prevent that sensitization. But now that the baby, that blood mixture, now mom has been sensitized to that RHD. So her body will always recognize that RHD. So if she gets pregnant again, she definitely has to continue to take that rig. It's a shot that they give the pregnant women to try to prevent a serious reaction from happening, because her body attacking baby's body because it sees it as a foreign. It's just very complex. But anyways, so I digress. So that would be like a sensitization, is that now she's sensitized to that RHD. Okay, moving on. IAT, this is a indirect antiglobulin test. It detects unbound antibodies in donor serum that could react with recipient red blood cells. This is used in the antibody screen and cross-match to ensure compatibility. The gel AHG, anti-human globulin gel technology, this is a method to perform the DAT and IAT using AHG, anti-human globulin, to enhance detection of IgG or complement binding, agglutination, and gel columns. Not sure if you guys are in your laboratory rotations, if you're in blood bank currently, have you guys started doing any type of gel testing? So what it is that instead of using the tube, we use a gel and we centrifuge that, and then we look for the gel columns and we grade them. And AHG is also used in two methods for IAT and DAT. That auto control, that's part of the antibody screen, and we'll talk about that more later. For the donor now, which we do the DAT again for the donor as well, but continuing on, we test for the ABO type forward and reverse. And what this is we are testing to mix the donor red blood cells with anti-A, anti-B, and anti-AB anti-sera. This is a monoclonal IgM from cell lines. And so we also here look for agglutination, and we grade it underneath a light. And we grade it between 0 and 4 positive, 4 positive being the strongest. And so the stronger the agglutination, that would be our result. So, and then for reverse typing, we would mix the donor serum with A1 and B reagent red blood cells. These are standardized cells known as A1B antigens. And we're also looking for agglutination. Agglutination shows us that there are antibodies, anti-A, in group B serum, for example. And so we can do this two methods, either tube or gel. And if there are any type of discrepancies, which is something else very big, you guys have to know discrepancies and how to fix them. So, for example, if there's a weak A2 in the reverse typing, so there's discrepancies in forward typing and reverse typing, which I'll get into later. But if there's a weak A2 in the reverse typing, what we do, how do we resolve that? We resolve that with low ionic strength saline, with LIS, or enzymes such as Vicin to enhance some antigen sites. So these are two ways that we would fix this type of issue. And so again, our role as MLS is to run the tube and gel testing, grade for agglutination, and resolve any discrepancies. And then we also do for infectious disease screening, which I'll talk about in another slide. And then we reconfirm donor ABO and RHD, and we reconfirm with weak D. Weak D is basically that we're confirming that there is, so while we're grading RHD, if we get a +1, that's a weak, but it's still there and it's still present. So we're going to retest that to confirm that. If it's there, it's weak again, then that product is going to be labeled positive, RHD positive. If we do the test again and it comes back negative, then what we'll do is that we'll label our product as RH negative, because we reconfirmed it and it's a negative. So something could have happened that created that first initial positive reaction, but we always confirm D positive. And so just be aware of these testing, and I'm sure many of you are going to be seeing these soon in your laboratory rotations. And then if you have any questions about this, please let me know. Infectious disease screening. So in this part of our testing, now that we've determined what our patient blood type is, if they have any antibodies, and if they're positive or they're negative for RHD antigen expression, or if they have a weak D antigen expression, we've already determined all of that. Okay, moving forward, now it's time to test for any donor blood for transfusion transmission infections. Okay, so the viruses that are we going to be looking for, the majority of them use CLIA or enzyme immunoassay. CLIA is chemiluminescent assay. Some of these use NAT, nucleic acid. And then for some of these also use TMA, which is transcription mediated amplification. And a lot of these, that TMA is a type of NAT. It amplifies viral RNA. And that NAT is that nucleic acid testing, and it amplifies also the DNA and RNA. And I'll get into that in a second. So it's important for us to know the screening methods and what they are, what their target is, how they work. So, and this is just a lot that maybe some, I don't know, my program wasn't, I don't know, but so look, you gotta really know the details. You gotta know how these screening methods work. I know maybe it could be tedious to have to remember all of these types of tests thing that we have to do, but unfortunately for our exams and even in the laboratory, but mostly for our exams, they drill us on these screening methods and these agents and the markers detected and if and the confirmation test. So unfortunately, yes, you're going to have to understand the mechanics of the screening methods. Okay, so I'm going to try to be very brief, try to explain it to you as best as I can. So for let's start with HBV real quick. So for HBV, okay, hepatitis B virus, the marker that we're going to test. And so the marker is basically it's on top of the antigen. So remember that the antigens are the bad guys. These are guys that have no business being around inside of us anywhere. The antibodies are our soldiers. They're the ones who defend us inside. And any moment that there is an invader inside, they send signals, and those signals charge to try to eliminate that threat. And, so we're looking for what's sitting on top of the virus. So that marker, that Hep B surface antigen, is one of the markers that we're going to look for. But hepatitis B not only has one marker, it also has antibody to the core antigen. So Hep B core antigen is another one that we're also looking for. And we're also looking for the hepatitis B DNA. And it's important to note that these viruses, we have windows in which time to be able to detect them in their infection stage, in their infective stages, okay? So for the hepatitis B surface antigen, for example, we have a window of 30 to 60 days of the infection to be able to see it in the body. Otherwise, after that 60 days, what happens is that it becomes harder for us to be able to find it in the body because we want to catch it during that infective stage. So, and then for the hepatitis B core antigen, we want to look that we want to be able to spot that within 6 weeks of infection. And we can use the screening methods for hepatitis B for CLIA and EIA. And I'm gonna write down what all that is so you can also read it and hear it. And then for the HBV, the DNA, we do this testing through TMA and PCR. And for that, we have a window of 20 to 30 days. And so we have to be able to test it within that time frame. And so for hepatitis C, we also use the same screening methods. And we're looking for the marker hepatitis C, the hepatitis C virus antibodies. This is a window of 6 to 8 weeks, and we also are looking for the hepatitis C RNA. We have a window of 10 to 15 days for this one. And for this one, for the RNA, we could use the NAT or the TMA. Remember, I said that those are similar, but so we need to be able to differentiate between the NAT and the TMA, which so for the NAT, it amplifies that viral RNA using the technique like TMA or PCR to detect early infections. So NAT is good to check for a shorter window than in serology. It uses pathogen-specific primers and probes detected by fluorescence lighting, and it's critical for blood safety. And for the TMA, it it's a type, like I said, it's a type of NAT. It amplifies RNA, but it uses reverse transcriptase to make a copy DNA, then RNA polymerase to produce multiple RNA copies. And it uses it also by fluorescent probing, binding that amplified RNA. And I know, ma'am, sorry, I might have lost you there for a second, but you need to be able to know the difference. So NAT is good for checking for shorter windows. And then for
HTLV, okay, you're like, what the heck is that, right? Well, that is human T lymphotropic virus. That is what that is. I know. And so for this one, we're going to be testing it through the antibody of HTLV 1 and 2. And also testing with CLIA and EIA. And then for syphilis, we do for, we're looking for the marker, the antibody T pallidum, treponema. I always say that, I always kill that word. But so we're looking for those antibodies of the T pallidum. And we do this through the EIA, and we also do RPR, and we use the cardiolipin reagent for that. And not sure if you have started serology yet, but we actually in blood bank don't do the syphilis. I never did that in my blood bank program. I did the syphilis testing in chemistry in the serology department at my hospital. And what it is you just sit down on a card and you measure the titers. And the higher the titer means more infective stages, right? So we have to test for all of these. All right, so moving forward on to the next step, the next few viruses that we have to test for. All right, continuing on. For HIV 1 and 2, we're looking for the marker, the antibody to HIV 1 and 2. And for this, we have a short window of 3 to 6 weeks. And for the assay, the screening method that we're going to use is CLIA or EIA. And of course, we're going to confirm that with using the Western blot. And so not only that, we're also going to be looking for the P24 antigen. We have a window of 16 to 22 days, and we're also going to use CLIA for that. Another marker for HIV 1 and 2 is HIV 1 RNA. So we're looking for the RNA of it, and we're going to use NAT for that. And the reason why is because the window is between 9 to 11 days. So remember, NAT tests for a shorter infective stage. So we want to try to catch it as early as possible. So we're going to use NAT versus TMA on that one. And so it's our job as MLS to run the CLIA or run the EIA or run the NATs and interpret these results and confirm positives, and also confirming with the Western blot and discarding any units. For T. cruzi, excuse me, for Chagas disease, you guys have heard of Chagas disease. This is another bug that this is a bug that we're going to be looking for, and we're going to be looking for the antibody to T. cruzi. And then we're also going to use it for CLIA and EIA. For West Nile virus, we're looking for the RNA, and for Zika, we're also looking for RNA. So both of these viruses, we're focusing on the RNA, and we can use the screening methods of NAT, TMA, or PCR. And then for us, we have to be able, again, to run these tests, EIAs, RPRs, NATs, and confirm positives, and also for TP and PA for syphilis. I didn't mention that in syphilis, but that is also important. And then also Babesia. I'm sure you guys have heard of Babesia. Babesia is another pathogen that we have to test for. It's most common here in the United States, and it's a tick-borne parasite that causes this Babesia. And so we need to know how to test for it. And the way that we do this is through indirect immunofluorescence assay, IFA or EIA. And if a patient is reactive to this, what we do is we let the patient know, but we defer them for a year. We also can test it doing NAT, nucleic acid testing, or PCR TMA, which again is similar to NAT, but we want to try to catch it early between a window of 7 to 14 days. So probably do the NAT for high risk patients, and then for us, we again just have to know how to run the NATs, run these exams on donor samples and discarding units and confirm positives with microscopy and any and also stained smears, gaseous stained smears, because we need to be able to look underneath the microscope for any type of inclusion inside the red cell and inside the red blood cells, because these bugs, these pathogens, they leave an intra erythrocytic ring, and so it's inside the red blood cell, and it's like a Maltese cross forms inside the red blood cell. And so we sit down underneath the microscope and we look at the blood, and if we see that there, then it's most likely that. And of course, with all of our testing to support our theory. So yeah, so you already know HIV 1 and 2, T. cruzi, West Nile, Zika, and Chagas. Excuse me, Chagas, Babesia.
This is our ISBT 128 label. This is the one that we're going to place on our unit, and basically it's just who, what, where, when, and why is this component, why was it made. So we're going to have the name of our blood component, the ABO and RH type of the patient that we typed, and then the collection facility where it's coming from or where it was performed. We're going to have the patient information, the donor and PT ID numbers, and then we're also going to have our date and time of expiration, if any anticoagulant preservatives were used, the approximate volume of it, the temperature requirement of the unit. It has to be prescription only. Has to say that it's prescription only. It could also has to say that it may transmit infectious agents, because even as much as we try to prevent any pathogens from being, infiltrating in these units, they can sneak by and trick us sometimes. It happens, unfortunately, but it needs to be there, and everyone needs to be aware of that. And we also need to identify the intended recipient and if it was a volunteer or a paid donor. So this ISBT 128, they scan it, and this is all of the information that they're going to get. So we got to make sure that everything is to the T and correct, because a lot of things can happen if we mess up on any of these issues. Blood components. All of the blood components that are listed here are important for the ASCP exam and for rotations and for your programs. And I'm going to break them down one by one, and I'm going to explain what they're used for, their QC, the temperature, the storage, the transportation, and their count increases, and also any coagulation factors that two of these, cryo and FFP, do have. Just briefly, I will make other slides on talking about the coagulation factors and the coagulation cascade. For now, we'll keep it brief so that you know what factors are in what product and why they're useful for what diseases. So just hang on and let's keep on going.
Anticoagulant preservative solutions. So, to be brief on this subject here, so anticoagulants prevent clotting during blood collection and testing, while additive solutions extend red blood cell shelf life post separation. So, for us as MLS students, we need to be able to know how to handle these in donor collection and processing. So, for the anticoagulant CPD and CPDA 1, this is used in the collection bags, about 63 mLs for that 450 ml blood, 1:7 ratio, and it's used to prevent clotting and preserve red blood cells. The purpose of it is to stop clotting by binding calcium, citrate, and supports red blood cells for 21 to 35 days at 1 to 6 degrees Celsius. It's important to know the amount of days that it preserves the red blood cell shelf life and the temperature in which it's kept. The components of that for CPDA is citrate, and this halts the clotting cascade. And in apheresis, we talked about citrate toxicity. This can cause tingling. Phosphate, it buffers the pH, which our pH is 6.8 to 7.4 for red blood cell integrity. For dextrose, it fuels our red blood cell glycolysis energy, and for adenine, this is that A and CPDA1. It boosts ATP, extending storage life to 35 days versus 21 days with only that CPD. And then for additive solutions, AS3, this is added to packed red blood cells after plasma removal. The purpose of it is to extend red blood cell shelf life to 42 days at 1 to 6 degrees Celsius. Maintains our hematocrit between 55 to 65%, and it reduces hemolysis by supporting red blood cell metabolism. A component of that is a saline. Saline for osmotic balance prevents red blood cell swelling. Adenine supports ATP synthesis. Glucose fuels red blood cell glycolysis. Mannitol prevents swelling. Blocker stabilizes membranes. For additive solution 7, this is a newer additive solution. It's added to packed red blood cells post centrifugation, designed to enhance red blood cell quality and extend storage. The purpose of this is to extend red blood cell storage to 42 days at 1 to 6 degrees Celsius, like AS3, but with improved ATP levels, reducing hemolysis, and better 24-hour post transfusion recovery. This has been noted in at least 80% of transfusions in that. Uh, and it optimizes red blood cell metabolism in low oxygen conditions, in a deoxygenated storage, for example. The components of AS7 is saline, maintains osmotic balance, adenine boosts ATP synthesis for red blood cell energy, glucose fuels red blood cell glycolysis, mannitol reduces red blood cell swelling, stabilizes membranes, sodium bicarbonate buffers our pH between 7.0 and 7.4, and it counteracts acid buildup from lactic acid from glycolysis. And disodium phosphate. This is additional pH buffering. It supports red blood cell membrane stability. So it's important for us to know the anticoagulant preservative solutions for the components that we have in the laboratory, and also for our testing of ASCP. Blood components. Now that we've discussed the additive solutions and the anticoagulants, it's time to discuss the components and break them down one by one. So, starting with red blood cells. These guys, we use them for anemia, sickle cell, thalassemia, a hemoglobin of less than 7 grams per deciliter, trauma, and surgery. We store it at 1 to 6 degrees Celsius, and we transport it at 1 to 10 degrees Celsius. For QC on red blood cells, we look for hemolysis of less than 1%. Hematocrit, we like to see 55 to 65%. And in addition to the storage, for 21 days it's kept with CPD, 35 days with CPDA1, and 42 days with a combo of the CPDA, the anticoagulant, and the additive solutions 3 and 7. So CPD and CPDA1, along with additive solutions 3 and 7, extend the shelf life to 42 days. And then we also, if the product is used, it would increase the count of a hemoglobin up to at least 1 grams per deciliter, and hematocrit would be raised up to 3% per unit. And for whole blood, it's rarely transfused. However, when it is used, it's usually used for trauma, for massive hemorrhage. It replaces red blood cells and plasma with limited platelets. We use anticoagulant CPD for 21 days as well as red blood cells. Same thing for 35 days with that CPDA1, and that's because of that adenine is for the ATP, and the citrate chelates calcium. That dextrose phosphate supports red blood cells. The QC of it is we also look for hemolysis being at less than 1% at expiration. Hematocrit, we look for between 35 to 45%. We test 1% of the units, also of a minimum of 4. And we also store it. We also transport it with validated coolers at 1 to 10 degrees Celsius. And for frozen red blood cells, as the name suggests, these guys are frozen. So these can be kept up to 10 years under negative 65 degrees Celsius. It's kept and monitored in storage. We usually freeze red blood cells for really rare types of types of blood. For example, Bombay would be one, and it would contain the glycerol for that preservation. Once it's thawed, it has to be used within 24 hours. And again, it's used for long-term storage for rare and autologous units, which means self donation. So if we have to ever donate, we donate to ourselves. So self. For leukocytes reduced, I put red blood cells and platelets together. They're not the same component, obviously, but they do both reduce CMV transmission, ALA alloimmunization, for example, like transplants and for TTP patients, and it also reduces febrile non-hemolytic transfusion reactions. And for the QC with this, we like to see white blood cells kept at a minimum of less than at least 5 million within the unit. We test at least 1% of the units. And for red blood cells, we store them at 1 to 6 degrees Celsius, whereas the platelets, we store them at room temperature, 20 to 24 degrees Celsius, and these guys have to be agitated all day. And of course, the red blood cells have a different expiration date, 42 with that additive solutions, 42 days with the additive solution, and then the platelets are usually good for 5 to 7 days in a closed system, which means that it hasn't been punctured or used yet. And so and then both of them, of course, they're good for that reducing of that of viral infections, of the alloimmunization and that CMV transmission, because it keeps the white blood cells from attacking any types of antigens in our body, any types of foreign antigens attacking our body. And so it keeps them at a minimum to where they won't hopefully affect a recipient.
Apheresis red blood cells. These we use them for anemia, and they're good for about 42 days with the additives and anticoagulant solutions. And for QC, we check for hemolysis being at less than 1%, hematocrit 55 to 65%, and we also test 1% of units. We also ask for a 16-week interval for apheresis donors. And it's our role as MLS to verify the anticoagulant additive solutions, to check for hemolysis and hematocrit, and issue as ABO and RH compatible in pack and coolers. For apheresis granulocytes, these guys are used in neutropenia with infection, fungal, bacterial, patients who are unresponsive to antibiotics, and they also prevent graft versus host disease because this product is irradiated, and they're also ABO compatible. The QC for these, they have to meet at least 10 billion irradiated, and we test 1% of units. The temperature, we keep them at 20 to 24 degrees Celsius, no agitation required, and we store it for 24 hours. And for the diglyceride red blood cells, it's just as the name suggests, diglycerized, which means that we're taking off the glycerol in this unit. It's used for rare blood types, for example, Bombay. It's also used for autologous storage. This is for self-donation and delayed transfusions, and it's frozen. It's kept frozen for less than or equal to negative 65 degrees Celsius for up to 10 years. And once it's diglycerized, we have to use it within 24 hours. Cryoprecipitate, aka cryo. This is the cold insoluble precipitate from thawed FFP. It's concentrated in specific factors for targeted therapy. It is prepared by thawing FFP at 1 to 6 degrees Celsius, collecting the precipitate and freezing it at negative or equal to 18 degrees Celsius. The factors in cryo are factor 1, fibrinogen, von Willebrand factor, factor 8, and factor 13, the fibrin stabilizing factor. The factors uses for von Willebrand disease, which are types 1, 2, and 3, provides that von Willebrand factor for platelet adhesion. For also uses for hypofibrinogenemia, which is low fibrinogen, so using DIC, massive transfusions. We also use it for factor VIII deficiency. It's rare. It stabilizes clots, it prevents bleeding, poor healing. Use it for hemophilia A. It's rare, factor VIII units. And recombinant concentrations are usually preferred. And it also contains fibronectin. And we once we usually thaw this, it's usually good for 4 hours in an open system, and in a closed system it's good for 6 hours. That means that the port of entry has not been opened. For QC, each factor has to meet their own criteria. I'm not going to name each QC interval for each factor, but it is in my notes, so go ahead and just hop on over to my notes and take a look at them, and you'll see the QC information there for each factor in cryo, as well as for FFP in the next slides. And the storage of this is frozen for 1 year. Again, thawed in 6 hours. Closed system, 4 hours pulled in an open system. Transportation is transported frozen on dry ice, still maintained at negative or equal to 18 degrees Celsius. And it's our role as MLS to thaw, pool, test factors, and issue for von Willebrand disease and factor VIII deficiency, and also pack coolers with dry ice. So no cryo for von Willebrand disease, von Willebrand factor, hypofibrinogenemia, factor VIII deficiency. It's not used for TTP. TTP uses FFP, and we'll get into that why in the next slide. So, and then and you want to know your QCs, which again, just go look at my notes and you'll look at them, because I'm not going to name each QC for each factor. Is a lot of information and I don't want to overwhelm you. Platelets. Platelets, we use these guys for thrombocytopenia, and in rare cases we use it for TTP unless there's bleeding. For the storage, we store it at 20 to 24 degrees Celsius with continuous agitation. And for the QC of platelets, we like to see a minimum of at least 55 billion present within the unit. And the pH, we like to see between 6.2 to 7.8. And it has to be ABO compatible. And because it is stored at 24 degrees Celsius, which is at room temperature, we do perform bacterial testing, and we use the BACT alert in order to help us do that. And so it's our role as MLS to verify the count, the pH, filter for leucio reduction if needed, and label 4-hour expiration for open system filtration. Again, issue ABO compatible and pack in insulated containers 20 to 24 degrees Celsius. And for pooled platelets and platelet leukocyte reduce, we also use them for thrombocytopenia, higher doses for adults. The QC for that is at least 220 billion, and within the unit, 4 single units, because we test 1% of unit within a month. The pH is also the same as platelets, 6.2 to 7.8. And the leukocytes reduced has to be also met at their QC interval. And again, these guys are also stored at 20 to 24 degrees Celsius. They're stored for 5 to 7 days in a closed system, sterile docking with bacterial testing, and 4 hours if pooled in an open system. So that's what we opened it. So it's our job as MLS to pool 4 to 6 units using the sterile docking for a closed system. Again, verify the count for a greater or equal to 220 billion within the unit. pH, leucio reduction, label 4-hour expiration for open systems, issue as ABO compatible, and pack in insulated containers. FFP, aka fresh frozen plasma. Fresh frozen plasma is one of those components that are incredibly valuable because it has all of the coagulation factors. All of them. Factors 1, 2, 5, 7, 8, 9, 10, 11, 12, 13, von Willebrand factor, protein C and S, and atom TS13, which is a deficient protein that causes TTP. With all of that said, I know We use FFP to treat TTP, as I just mentioned. We also use it not to directly treat HUS, which I've seen in my notes, HUS there that I've seen ASCP kind of like ask about, but it's not that we like treat HUS. What it is that HUS is part of the MAHA triad family. Okay, I'm not sure if you guys know what MAHA is yet. So HUS, okay, it's called hemolytic uremic syndrome. And this syndrome is a Shiga toxin associated. It's usually in children, and they usually treat it with supportive care like hydration or dialysis. And an FFP is not indicated because it doesn't address the Shiga toxin. However, it could help in complement dysregulation. For example, they treat the children with medication. If that medication is not available, FFP may be used to temporarily to supply the complement proteins. So that's where I've seen that before. And then so keep going. So we store it at negative or equal to 18 degrees Celsius for 1 year. Once we thaw it, we have to use it within 24 hours in a closed system at 1 to 6 degrees Celsius. But if you spike it in an open system, it's 4 hours max due to germ risk. And so we have to know as MLS to thaw it at 37 degrees Celsius, check for factor 8, label for 4 hours for an open system, and ship in coolers at 1 to 10 degrees Celsius. So remember expiration, 4 hours for open system for FFP, and 24 hours closed.
Temperature, storage, and transportation. So I've already told you the temperatures and transport methods for all of these components, but just to be very, very brief and very thorough, for all red cell products, they're stored between 1 to 6 degrees Celsius, transported 1 to 10 degrees Celsius. Frozen red cells are kept at negative or equal to 65 degrees Celsius, and they're transported in the frozen state. All platelet products, because they're a bunch of babies, they have to be rocked and continuously rocked with gentle agitation and maintained at room temperature between 20 to 24 degrees Celsius. They are also transported at that same temperature, and maximum time without agitation is 30 hours. That is all that they can tolerate. For all frozen plasma products and cryo, they're kept at negative or equal to 18 degrees Celsius, and they are transported just the same. All thawed all thawed plasma products are stored between 1 to 6 degrees Celsius and transported at room temperature 20 to 24 degrees Celsius. Thawed cryo, AHF, and apheresis granulocytes are stored and transported at the same temperature of 20 to 24 degrees Celsius. Special conditions in blood components. All right, guys, we're reaching the end. So if you hang on this long, you guys are true warriors. So these special conditions are conditions that we're going to now do to the component if we have to. And we usually do this in very special cases. So for patients who might be really sick and might need irradiation, and we also wash these cells. We also are doing saline replacements, and we're going to cover all of this right now. So these special conditions, they modify the components to basically reduce risk. For example, graft versus host disease, allergies, and we'll perform and oversee these types of tests. For example, for irradiation, we use the gamma rays from cesium-137 or cobalt-60 or X-rays to inactivate lymphocytes, preventing graft versus host disease due to T cells, right? So we use it for immunocompromised patients, for stem cell transplants, neonates, babies, TTP, to stop donor T lymphocytes from attacking recipient issues. And we also, we dose it based off 25 gamma rays, 25 rads to center. And we store it same as a base component of red blood cells of 1 to 6 degrees Celsius. Expiration is 28 days from irradiation or from original expiration date, whichever is first, per AABB and FDA. And for 14 days, and also in some guidelines, and that is noted in BCSH and CE. For platelets, there's no change in shelf life. And it's our role to irradiate units, use gamma cell with cesium-137 or ray cell with X-ray. Label irradiated as it's issued, and we verify dose with indicators. So, know the 28 limit for red blood cells and no change for platelets. And for washing, this is how we remove plasma and additives or allergens from red blood cells or platelets. We use saline, 0.9% sodium chloride, and cell washer. This is known as Hemonetics ACP-215. We use it for IgA deficient patients. It prevents anaphylaxis, severe allergic reaction to plasma proteins, and we removing potassium additives in massive transfusion. And we wash 99% of the plasma, reducing reactions, especially in fetal non-hemolytic transfusion reactions. Febrile non-hemolytic transfusion reactions, as in fever. And we store it between 1 to 6 degrees Celsius. We keep it for 24 hours post wash, and in an open system it increases bacterial wash, so we keep it at 24 hours from wash time. This is per AABB FDA standards. So it's our role as MLS to run the washer. It's 3 to 6 cycles with saline at between 1500 to 2000 RPM. We resuspend in saline. Make sure that the unit is at least with a hematocrit of 55 to 65% within the unit. Label the unit as washed and issue within 24 hours. So know that washing is for IgA deficiency and know that it has a 24-hour limit. For saline replacement, this is part of the washing process. This is where red blood cells and platelets are resuspended in saline after plasma removal. We use it to replace removed plasma with isotonic saline, 0.9% sodium chloride, to maintain the volume and osmotic balance, reducing allergens or additives, for example, for IgA deficiency, often used in washed red blood cells and or platelets. We store it the same as the wash component with red blood cells, 1 to 6 degrees Celsius. We keep for 24 hours post-wash. So expiration is 24 hours from the saline addition and in the wash. And then it's our job as MLS to add the saline, which is 100 to 200 mLs for red blood cells, with that final hematocrit of giving us that 55 to 65%. We spin to pellet, 1,500 grams for 5 minutes. We remove the supernatant and we label it as wash and saline replaced, and we issue it as such. So know the saline replacement for washed red blood cells and know that it has a 24-hour limit.
Stop, drop, and recall. All right. In this slide, I'm not going to help y'all at all. Y'all gonna have to go into my notes and go get the answers for this, because I'm not gonna help you. I want you to try to recall, and if you already know it, great. You don't have to do this. But if you don't know and you still struggle with, well, what are pooled platelets used for? Or what is cryo used for? If you were in your blood bank rotation right now and you're there sitting there just studying, the instructor told you, why don't you go sit down and go look at some units or something, or I don't know, they told you to go do something, go do that. And then all of a sudden she looks at you and she says, hey, and you're like, hey, and she's like, what is cryo used for? And then you look at her and you pause and you're like, you already messed up right there. She failed you. So you have to know, like, boom, oh, okay, real quick, hemophilia A, you know, damn, like I just gave y'all an answer. So my point is, like, if you're in your rotation, if you have an instructor, my blood bank instructor, my rotations were questionable, but the blood bank instructor, she was cool, and she always drilled me, and I was just chilling most of the time. She would tell me to, oh, do the antibody panels or do this or do that, and I would do it, whatever she wanted me to do, I would do. But then she would just randomly just be like, hey, Thalia, what's this used for? Or what are the coagulation factors in this product? Or are there any coagulation factors in here? Or what? She would just like randomly drill me. And so, you got to be prepared to maybe have an instructor like that one day. And obviously for your test, you got to know it. All right, guys, it's time to test your knowledge. Let's see if y'all was paying attention. All right, so question number 1. A donor experiences tingling lips and muscle cramps during apheresis collection. This is most likely. Let's go through one by one. A vasovagal syncope, citrate toxicity, hematoma, or an allergic reaction. Let's go through why the right one is the correct answer. So the correct answer here is B. It's citrate toxicity. And this occurs from citrate anticoagulant binding to ionized calcium, and it disrupts the nerve and muscle function. This is important to know because we have other options that are listed here. And so we also have to know the symptoms of the citrate toxicity, because that's the option here. Citrate toxicity, well, what's the symptoms of that, And so remembering what that is that it's the paresthesia, which is tingling and cramps, and we're supposed to pause collection and administer oral calcium carbonate. And it can't be C, a hematoma, because we know that that's bruising and swelling from a vein puncture. No. D is not allergic because it didn't mention that the patient has hives or itching from histamine release. No. And then A, vasovagal syncope, well, it's the patient, it didn't say that the patient fainted. So it's not that either. So that's how we're supposed to do the process of elimination for this test. All right, question number 2. During RH typing, the immediate spin with anti-D is negative, but the weak D test with AHG is positive. How is the donor unit labeled? All right, so we think this through about everything that we've learned. So A is RH negative, B RH positive, C weak D positive, where we would defer, and D for RH inconclusive. So the answer here is B. We would label the donor unit as RH positive because positive weak D tests, the agglutination with AHG, the anti-human globulin, after the anti-D, and the IgG incubation at 37 degrees Celsius and washing confirms the weak D antigen. So we would label it as RH positive to avoid anti-D sensitization in RH negative recipients. Means that we wouldn't expose the patient to the RH antigen. And so the initial negative immediate spin indicates the weak expression, but the weak D is considered RH positive for donors. This is via AABB standard. And A is wrong because negative weak D or initial RH negative would just be negative. And C is wrong because weak D is RH positive and it's not deferred. And D is wrong because it's conclusive with weak D tests. So we need to know what immediate spin in IgM and anti-D versus weak D in IAT with AHG, which remember is indirect agglutination, and anti-human globulin. Don't get scared by these big words or nothing. I'm going to write all this down in my notes. But so if initial negative, no weak D needed. right? So if we run the test and it's just initially it's negative, there's not a weak D that we need. But if there is that weak antigen expression, then yes, we do have to follow up with that. And so that's why it's important to know. The weak D, how to be able to run the weak D, how to label RH, and how to document for compatibility testing. Y'all still good? Question number 3. What is the primary marker and method used to screen blood donors for hepatitis B virus? Is it A, anti-HBC and EA-CLIA, or is it B, HBsAg, EA-CLIA, or C, HBV DNA, not TMA PCR, or D, anti-HBs and serology? Okay, well, I'm going to tell you the answer. The answer is B. And it's B because the primary marker for HBV screening in blood donors is hepatitis B surface antigen, HBsAg. It's detected by enzyme immunoassay, EIA, or CLIA, chemiluminescent immunoassay. And we like to test it in our window between 30 to 60 days. And the hepatitis B surface antigen indicates active HBV infection, acute or chronic. And any positive units are discarded and the donors are deferred permanently. This is per AABB and FDA standards. A is incorrect because anti-HBC detects past exposure. It's a secondary screen. And so it's reactive and it requires NAT confirmation. C is incorrect because HBV DNA by NAT and TMA and PCR is supplemental for early detection, not primary. And D is incorrect because anti-HBs indicates immunity, not infection, and it's used in recipient testing. So a tip for you is to know the hepatitis B surface antigen as primary, NAT for confirmation, and permanent deferral. Irradiation of components is used to A. Extend shelf life to 42 days, prevent TA graft versus host disease, reduce hemolysis to less than 1%, or D. Increase pH to 6.2 to 7.8. The answer here is B. Irradiation uses cesium-137 and or cobalt-60, 25 gamma rays to center, and it inactivates lymphocytes to prevent transfusion-associated graft versus host disease in immunocompromised patients, and for example, transplants and neonates babies. And the storage of irradiation product is the same as base as red blood cells, 1 to 6 degrees Celsius, and it expires 28 days from irradiation or original, whichever is first. And so we're looking at A. We know it's not A because additives such as AS3, AS7 extend shelf life. And it can't be C because additives reduce hemolysis. And D, pH for platelets. So that has nothing to do with irradiation. So on the exam, they're going to show you these questions that have these super intimidating options and questions, but the key to be able to answer their questions is to be able to understand all of it. So here we have to know the radiation component is for 28 days, not 42 days, because 42 days is extended by these additive solutions. So right there you know it's not A. And then of course then you look at the other ones and you're able to just apply that process of elimination process through every single question, those 100 questions that you're going to see on your test. And if once you're able to really find those little intimate details that stand out and it's like, no, that can't be it, that had, what, and that one, it doesn't even belong there, you will be super after that. All right, guys, last question. Question 5. HIV. What is the primary marker and method used to screen blood donors for HIV acute infection? Is it A, anti-HIV 1 and 2, Ia clia? Or is it B, P24 antigen, Ia clia? Or HIV RNA, NAT, TMA, PCR? Or is it D, anti-HTLV 1, 2, serology? The correct answer here is C, HIV, RNA, NAT, TMA, and PCR. The primary marker is the HIV RNA and is detected by NAT, nucleic acid testing. This uses transcription-mediated amplification, TMA, and or PCR, polymerase chain reaction, if y'all remember. NAT detects viral RNA in the early window period before antibodies or P24 are reliably detectable, ensuring safety for blood units. This is per AABB and FDA. Positive units are discarded and donors are deferred permanently. A is incorrect because anti-HIV 1 and 2 by Ia and Clia detects antibodies in window of 3 to 4 weeks, not acute. B is incorrect because P24 antigen by Ia and Clia is detected between a window of 16 to 20 days and is less sensitive than NAT. D is incorrect because anti-HTLV 1 and 2 screens for HTLV, not HIV. So, again, remembering and understanding all of the viruses listed here. HTLV ain't even HIV. Okay. And so it's like, so that's what I'm saying. It's like there's always going to be one that's like, okay, that test that doesn't even go there. So that right there, that test is not even for HIV. Okay, and the other ones, yet look, the question is here. Look, the question is, what is the primary marker? So they're always looking for the best possible answer. Like, yeah, that one is, yeah, you could test it, but the thing is that we really are trying to test it at an earlier window. And the best way for us to do that is that using that NAT that detects it in that early window before those antibodies are reliably able to be detectable. And just like that, we're finished. Well, I don't know how many of you guys held on for that long, but if you did actually listen to everything that I said, y'all is a real one. And thank you for listening. And if you like what I said, give your girl a like and subscribe to my channel. That way, next time I drop the next content, you'll be able to know when I drop it. And now, I do take long to drop videos because I'm just starting out. I don't really know what I'm doing. I'm just kind of using my high yield notes and trying to just communicate them to the students of the world, wherever you guys are. And so, just to offer a brief summary of everything that we discussed, we discussed donors, adverse reactions, screening, deferrals, processing, serology with ABO, RH and weak D, DAT, IAT, infectious screening with CLIA, IA, NAT, TMA, for HBV, HIV, Babesia. We talked about anticoagulants like CPD, ACDA, additives like AS3, AS7. We talked about storage, blood components. We talked about special conditions like irradiation. We talked about diseases such as like von Willebrand disease. We also talked about cryo, what like the components are used for. Like cryo is usually used for with von Willebrand factor for von Willebrand disease. And also, we talked about platelets and the minimum that they have to be within the unit. That's super important. Don't forget that. Uh,